Good afternoon, everyone, and a very warm welcome. My name is Tisela Hansen. I'm the coordinator of international relations and advocacy at Dianova International. And it is a real pleasure to welcome you to today's webinar, Beyond Stigma, Dignity, Intersectionality, and the Right to Care in Drug Policy and Services. Today's event forms part of a collective effort that many civil society organizations continue to promote following 26 June, reminding that international community that the stigma remains one of the greatest barriers to the full enjoyment of human rights for people who use drugs. While public attention often focuses on drug itself, far less attention is paid to the discrimination, exclusion, and structural inequalities that continue to prevent millions of people from accessing healthcare, protection, justice, and opportunities to live with dignity. So before we begin, I would like to express our gratitude first to Youth Rise, our co-organizers, for their outstanding collaboration, commitment, and partnership throughout the preparation of this event. Thank you for that. It has been a real pleasure working together, and we are proud to host today's discussion. My sincere thanks also to our exceptional panelists and friends. Thank you for your time and your expertise. Your voices are essential to ensure that these conversations remain grounded in reality and centered on people. And I would also like warmly thank everyone who has joined us today from around the world. Very special thank you to everyone working behind the scenes. You're so important to our communication team, interpreters, technical colleagues, because events like these are always a collective effort. And before we begin, just a few practical reminders. This webinar is being simultaneously interpreted in English and Spanish, so please select your preferred language using the interpretation button at the bottom of your Zoom screen. The chat will remain closed throughout the session. However, if you would like to ask questions, please use the Q&A box. And now it's my pleasure to introduce my colleague, Andrea Gomez, the co-moderator. He is the high-level advocacy and communications lead at Youth Rise. He's a drug policy communication professional with several years of experience working in treatment, services, and advocacy organizations, helping to shape communication strategies and amplify the voices of young people and communities affected by drug policy. Andrea, thank you very much again for your partnership, and over to you.
Hi, Gisela. Thank you for that introduction, and hi to everyone that's here. As Gisela said, I'm Andrea. I'm a member of Youth Rise, an international organization that represents young people who use drugs or are impacted by drug policies around the world. Really happy to have this quite timely discussion, because I think stigma is something that we're always discussing within the drug world. It's something that completely shapes our attitudes towards services, whether it's drug treatment, harm reduction, information on drugs, our understanding of who should be accessing them, but I think quite importantly on the attitudes of people that should be using these services or are the targets for these services, that quite often stigma can be a big barrier for people choosing to access them, understanding whether it is for themselves, and have quite a impactful force on your own attitudes towards what your drug use looks like, whether it is acceptable for you, whether you see it as acceptable within society, and what you should do about it, or if there's anything to do about it. So I'm really excited to have quite a complete panel here that's going to cover it from a lot of perspectives. Here I'm going to just introduce some of our panelists, and Xenia Ortiz has worked in the field of harm reduction for 10 years, progressing from direct care in a center to outreach work. Through this time, Xenia made a gender perspective the central focus of her work. She is the coordinator of the Robador Harm Reduction Center, working to eliminate barriers to access and align interventions with the complex realities of the lives of service users. Joana Canedo is a community organizer, researcher, and drug user rights advocate. She is the campaign coordinator and researcher at the European Network of People Who Use Drugs, supporting advocacy, research, and community-led initiatives across Europe. She is currently pursuing a PhD at the Institute of Social Sciences, University of Lisbon, researching drug user movements. Joana also co-founded Manage, a peer-led collective of women, trans, and queer people who use drugs and or engage in sex work in Lisbon, Portugal. Jalal Uddin Chowdhury is a public health and community development professional from Bangladesh. He is currently working as an HIV navigator official at Bandhu Social Welfare Society, one of the leading organizations in Bangladesh dedicated to improving the health, rights, and well-being of key populations and people living with HIV. He is also the youth focal point at Brave Dimension Social Welfare Society, a youth-led organization promoting the rights, health, and well-being of gender-diverse communities and other marginalized groups. Sofia Posada Bernal is a clinical psychologist, criminologist, and researcher from Bogota in Colombia, interested in substance use and dependence. She's worked in different harm reduction initiatives in Colombia, leading educational workshops, doing drug checking, and conducting research in the field of substance use and mental health. In the past, she has also worked with vulnerable communities, providing psychological support for people who inject substances in safe consumption settings. And she is someone who uses drugs and a proud part of the LGBTQ community. So this is a really beautiful panel, I think, that is able to talk about stigma, its shapes in a lot of perspectives, which I'm really excited for. And I think with that, I can bring it back to you, Gisela, to start our discussion.
Thank you very much, Andrea. And thank you once again to all our amazing panelists for being here today. This is going to be an amazing conversation. As you know, rather than an individual presentations, today's webinar is designed more like a very natural conversation. So we hope to create a space where different experiences can complement one another and where we can collectively reflect on both the challenge we face and the solution that we need, but very grounded in real life experiences. So let's begin with our first question to our amazing panelists. What does the stigma look like for the communities you represent or work with? And how does it impact the way they engage with society and with drug-related services? If anyone wanted to go first. Sophia?
Yes. So I think depending on the community, there's different kinds of stigma. I have had the chance to work with different kinds of communities, where it be sex workers, trans population, people who inject substances, ravers, different communities. But what I have noticed is that for all of these communities, stigma looks like disinformation regarding policy, regarding, for example, here in Colombia, we have the personal dose kind of law, and some people don't know about that, so police can take advantage of that. Disinformation regarding, for example, the quality of the substance because we don't have drug checking services. And also stigma can look like barriers to access services, both health and mental health, because there's a tendency for the medical perspective to reduce the problems to consumption. So there's this idea of go solve that part first and then come back to us. When we know that most people don't really develop a problematic substance use disorder, and when sometimes people do develop this can be a symptom of something else, where it be structural issues, for instance. And I think stigma can also look like a lack of safe spaces for substance use. From Antidoto, we are working with communities in areas of the city where they have low income resources, and there's this idea that if you buy substances in a territory, then you have to go to another territory to use the substance. Otherwise, the groups that control that territory can harm you. And in Swacha, where we work this weekend for Support Don't Punish, two people lost their lives because they bought substances and then used them in the same territory. So I think that, and also it impacts people because there's a lack of representation of drug users in policy and all of these communities as well. So in a way, they are silenced because they don't take part in the conversation. So I think in general, that's what stigma looks like for the communities I work with.
Thank you very much, Sophia. Thank you for sitting the time as well. Joanna, please go ahead. Thank you.
Yeah, I would add that stigma begins when there is a us and there is a they. And this is how policies and services are built upon. So let's imagine a service led by people who use drugs and who takes drugs, including maybe also not only those that use, but also those that sell. And let's see if we look at drug use not only from the perspective of a brain disease disorder or to reflect on the disorder part, but has something that is part of the life of people, like all of us, we are drug users after all. And if we build not only based on the needs, and the needs are much more than they go beyond the drugs themselves. They go for housing, they go for employment, they go for gender equality, they go for a world without xenophobia, xerophobia, male chauvinist violence. If we build up on these values, we'll bring a more a holistic approach to drug use itself, because then we'll understand that the problems are not the drugs themselves. The problem is more structural, as Sophia was mentioning. And when we build policies, this distance creates, it's kind of a myopia, you are looking far to the problem and you are not really engaging people. Not only, I don't even talk about the process stepping, like process tracking of designing with the people use drugs, implementing, evaluating, but keeping people use drugs in the leadership, because we'll know better what's better to us. And I guess when we look beyond drugs, then we find other perspectives that are way more important. For instance, for me, I've been working with women using drugs for the past years, and I consider myself a community organizer, and also a person who uses drugs, but I put my time on community building. And when you find the space that everyone feels safe to contribute, then you are giving up from your own leadership and creating like a collective leadership. And I think from our privilege as workers and reductionists that we've been here for so long, it's to create the space to be taken on by those that sometimes we consider them. And yeah.
Thank you, Joanna. Super important, the idea of us and them, and this huge barrier that we create just with language, but language which is reflecting what we think, the good, the ones, us and them, and how intersectional approach is key in order to design and implement good policy services and so on. We will talk about participation a little bit more afterward, and thank you for that. I think, Jalal, you raised your hand before.
Yeah, I did.
Okay, please.
Thank you. Thank you. Can I speak?
Yeah, please go ahead.
Oh, thank you so much. Thank you so much for having me, and greeting all from Bangladesh. So, regarding the first question on my thoughts and view, so if I can speak that in Bangladesh, stigma is one of the biggest barrier faced by the people who are living with HIV and other marginalized communities, including people who use drugs, sex workers, transgender people, and men who have sex with men. The stigma is actually not only social, it also exists with our healthcare systems, workplaces, families, society, and even friend groups and government institutions actually. So where I work, in every day I experience as a HIV navigation officer. So I often meet people who like to delay their HIV testing or stop taking treatment because they fear being recognized. They fear being recognized at a healthcare facility and being judged by healthcare providers and people surrounding. Actually, you know that the situation in Bangladesh, so so bad. So some people travel long distance just to reach services anonymously, while others completely avoid seeking healthcare because they fear discrimination. Actually, they fear discrimination. They fear to disclose their identities. They fear that someone judge them. Like this. For people who use drugs actually, who put injection in their body, face stigma more seriously. Because they are being intensified by criminalization, by our government, by our society, by our families, whatever. Everyone who use drugs in Bangladesh have no rights. our people, our society, our family don't think them as a human. They think them as a disgrace. That you are not both for the family. So this is so actually disgusting for me too. So describe. From my experience, the people who use drugs are frequently viewed as offenders rather than individuals who need healthcare and support. That is absencing here actually. This creates fear and mistrust toward public services instead of seeking harm reduction, HIV prevention, or treatment services. Many remain hidden until their health becomes critical. Whenever they near to die or become AIDS, so they have no option left actually. So they had to come out for treatment, but there is no time left. Sorry to say. Stigma isolates people. In my view, stigma isolates people, affect their mental health, weaken treatment adherences, and ultimately undermine public health efforts. From my experience, I can say when people feel respected, accepted, they are much more willing to engage with services and continue their care, continue their life, a happy life to live in, actually. So it's really a bad situation. You know that 170 million people right now in Bangladesh, 8.2 million people use drug in Bangladesh. Most of them are young people. You know that 18 to 25. It's actually 4.9% of Bangladeshi people who use drugs. Only 13% people are in treatment. You know, rehabilitation centers, counseling, mental health support is very limited in Bangladesh. This is very disastrous to say that. Okay, thank you.
Thank you very much, Alaa, for giving us this overview for the local situation, and especially to point it out the very direct relation that so many people establish between use drugs and criminalization, which is key in our debate today. So thank you, Jalal. And last but not least, in our first question, Xenia Ortiz. Xenia, cuando quieras, adelante. Gracias.
Hola, primero de todo, gracias por la invitación. Y pues respecto al estigma, también veo que aquí se entiende como el mundo de drogas como un mundo aparte, en vez de que formamos todos parte del mismo mundo, y es otra dificultad más de la historia de la humanidad, porque al final nos arrastra y nos persigue. Forma parte de la sociedad, de hecho, ¿no? Desde los inicios. Entonces, que igual no nos estamos inventando nada nuevo ni estamos abordando nada nuevo. Lo único que el estigma sí que es verdad que es algo que nos atraviesa en todas nuestras fases, ¿no? Desde lo individual hasta lo comunitario. Y sí que es verdad que en nuestro recurso hay una parte comunitaria que sí que tenemos muy en cuenta, que es que yo no puedo trabajar con un individuo, con una persona sola, sin tener en cuenta que forma parte de una comunidad. Entonces, el estigma lo trabajaré con esa persona que seguramente también le atraviese un estigma o sienta un estigma hacia sí misma, como hacia la sociedad, que también está como favoreciendo ese estigma. Y sí que entiendo parte de ese estigma como una especie como de miedo a lo desconocido. Y entonces es verdad que una de las maneras igual de poder trabajar igual ese estigma es abordar ese miedo, que el miedo de dónde sale el desconocido, el poder entender esas claves de qué es lo que te da miedo. La pobreza te da miedo, o igual ya has vivido una experiencia previa en tu ambiente más cercano, que igual, por explicaros un poco, en Barcelona también sufrimos mucho con la heroína, con sobredosis también, muchas muertes por sobredosis. Entonces hay comunidades, hay barrios, hay zonas donde perdieron muchos vecinos y vecinas por sobredosis. Entonces, cuando se trabaja ese estigma, hay que saber que muchas veces viene por ese miedo a volver a repetir otra vez esa fase de la historia. Y luego hay personas también y comunidades que igual no lo han vivido nunca y tienen miedo a que eso les llegue a su propia comunidad. Entonces, Luego, además, nos encontramos que sí que hay barreras de acceso que están atravesadas justamente por ese estigma. En muchos acompañamientos que ofrecemos a personas que acceden al centro, en una consulta médica, el doctor, doctora o desde servicios sociales intervienen con el educador o educadora en vez de con la persona que está interviniendo o que está interesada en esa actuación. Entonces, aquí sí que intervenimos un poco como para visibilizar que la voluntariedad y el interés es de la persona, no de quien la acompaña. Entonces, siempre buscando, pues como ha dicho Joana, un poco como la autonomía también de la persona, pero sabiendo que el estigma atraviesa y atravesará igual muchas de las fases donde quiera cambiar o donde quiera acceder esta persona, y por eso también como que intentamos facilitar esa rotura del estigma, sobre todo si la persona lo percibe y para la persona es una limitación, digamos.
Muchas gracias, Xenia, y bueno, y sobre todo por poner ejemplos prácticos, ¿no? De cómo se reproduce el estigma, de infantilizar a las personas en los servicios e incluso invisibilizarlas, ¿no? Ni siquiera dirigirse a ellas, sino a quien le está acompañando en ese momento a hacer la gestión, arrebatando el protagonismo de sus propios procesos e historias. Muchas gracias, Xenia. Thank you all very much. Thank you all very much for your amazing answers and listening your reflections. What struck me the most is that stigma, it's not only interpersonal, it's institutional, it's structural. And these stories remind us that reducing stigma is not simple about, changing the language, which is great, which is good that we talk about that, but it's not just only about changing language or attitudes. It requires changing the systems, practices, and policies, which is key and urgent. So with that in mind, I would like now to hand over again to Andrea, who will help us to explore why many of these barriers continue to persist. Thank you, Andrea.
Thank you. Yeah, I think we've touched on a lot of very interesting framing. I think Joanna put it well, that we are ultimately building this world of us versus them. But as other panelists also realized, that we brought it up, we're all people that use some sort of drugs. We are all people that are impacted by public health systems that are, maybe creating these barriers that are a bit different. So that's kind of our second question that we wanted to put to the panel on: what do you see as the biggest barriers that drug policies and drug-related services are failing to address when trying to respond to stigma? I'll leave it open again if there's anyone that wants to jump in for that. Yeah, Sophia?
Yes, so I want to agree with what Xenia said regarding fear, because I think one of the biggest barrier is the judgment by non-users or people who don't know about substance use. And sometimes this judgment is not even their fault, but it's the fear, and it's the response of the fear campaigns that, for example, some politicians use, like is the case in Colombia, where we now have like a more right-wing president who has a mano dura campaign against drugs, against consumption. So it goes with fear, but it also goes with ignorance, because people are not getting the information. And this results in the exclusions of users from decision-making spheres due to stigma. So I think the biggest barrier is like a disconnect between users and non-users, and between users and spheres where their decision-making is taking place. So I think the barrier is making decisions without considering drug users' insights, deciding for them from a moralistic point of view that lacks actual evidence. So, for example, in Colombia, they want to go back to use glyphosate for destroying coca plantations, when we know that this is bad for the environment, when we know that this is bad for people's health because it can be carcinogenic. But this discourse of violence, of mano dura, is what our next president is advocating for example. And I think this goes back to not seeing substance users as people with rights, with autonomy, and with valuable information to shape policy and services. So I think it's important that we have more inclusion of different communities affected by prohibition. So not just users, but also the farmers that they're spray with glyphosate, the indigenous communities, the people in the periphery of big cities, sex workers, people displaced due to armed conflict, and people who have lived prohibition and have been affected and impacted by it in a different way. For example, undocumented immigrants as well. They all have different perspectives that are very valuable that we should consider and take into account. And I think a very big barrier as well is the separation of services. When we just look at a single part, when we need to have a more holistic approach and we just need to have more of a collective effort. So we need the social workers, the psychologists, the toxicologists, the peers, which are super important, the lawyers, the harm reduction services in all of their levels, and people who also work with gender issues. So I think for me, that's like the biggest barrier, the disconnect and the exclusion of users and people who represent certain communities from those spheres. Sorry.
Yeah, thank you, Sophia. That's such a good point. I think looking at how you can include people that are involved in the entire drug chain, whether it is people from the level of production, which makes some sense for certain countries more than others, to those selling them, to those producing them, to those consuming. I think it's such an important approach to make sure that interventions are, reflecting reality. Shenya, I'm going to pick on you to jump in on this.
Un poco repetiría lo que ha dicho Sofía, porque creo que es un poco la base de todo. Al final es crear protocolos, crear políticas, crear circuitos sin tener en cuenta lo que necesita esa persona. Entonces, no crees lo que crees, estás destinando unos recursos, ya sean sanitarios sociales, pero ya recursos de bastante economía y esfuerzo al final profesional a algo que no sabes si va a dar respuesta a una necesidad real, una necesidad real. Entonces, aquí en Barcelona pasa un poco lo mismo también, pero además pasa que las barreras, sí, nosotros intentamos como acceder a una red que ya existe, ¿no? Una red sanitaria, una red social que ya existe, para que la persona pueda hacer uso de esos derechos que tiene como ciudadano o ciudadana. Pero lo que nos pasa es que esos recursos están totalmente desbordados, están colapsados. Entonces, allí es como, y esta gente extraña o ajena no puede acceder, como no, si ya no formaba parte de esto, ahora tampoco, porque ya como que estamos colapsados. Y además porque creen que tienen como más dificultad en se cree que tienen más dificultad en esa intervención, como que es mucho más compleja. Entonces, además, como que se visibiliza solo la dificultad relativa al consumo, no solo en otro tipo de dificultades o necesidades que tenga la persona. También creo que una de las barreras es qué consideramos urgencia o emergencia, porque al final nos encontramos muchas veces que hay urgencias realmente sociales y sanitarias con las personas de las que sufren, las personas que atendemos, y que por el simple hecho de consumir sustancias no pueden acceder a un servicio de urgencia, cuando realmente igual tienes una mujer que ha sufrido alguna agresión en calle, o tienes una persona que lleva 4 días sin consumir, en un estado de insomnio, con un consumo muy alto, sin un entorno seguro, durmiendo en calle. Quiero decir, tienes muchas dificultades añadidas además, y esa persona necesita ser atendida. Y si por el simple hecho de haber consumido o de ser consumidora no es atendida, porque no tiene, bueno, no es considerada como el resto de ciudadanía, que igual no verbaliza esa dificultad. Y para nosotros realmente una barrera es que en los recursos que ya existen no exista esa mirada de reducción de daños. Al final, creo que podría implantarse la mirada de reducción de daños en todas y cada una de los servicios que ya tenemos, que sí sé que están colapsados, al menos aquí en Barcelona, pero podría al menos dar cabida a toda la comunidad o toda la diversidad de personas que existe, que al final el servicio está hecho para la persona, no la persona para el servicio, que creo que hay una falta de mirada hacia el servicio o hacia la persona. Si el servicio está hecho para la persona, estas personas tendrían que tener cabida en todos los servicios que ya tenemos creados.
Thank you. Yeah, I think the point on systems being overwhelmed is so important around the world. We're seeing this with public health and health systems being unable to respond with drugs, which it is such a complex issue. Doesn't just touch on health, touches on social situations, employment, legal status. And I think it's complicated to respond to these things. Joanna.
So getting back to the history of harm reduction, it can be complicated to answer from a systems perspective, but we know that all harm reduction interventions start with the community. So peers introduced the first needle exchange programs. Peers start delivering naloxone peer-to-peer without prescription. Peers start developing safer spaces, peer-led safer spaces for using drugs. Peers started always what we needed in terms also of under the HIV umbrella to solve out a public health crisis in the 80s and the 90s. That people use drugs were dying and keep on dying nowadays due more to the toxic supply. We see other examples, for instance, on safer supply that came from peers. When I say peers, like lived and living experience. So sometimes we discuss a lot about the service users relation, and we forgot that the community was maybe the kickoff of many of the answers we have nowadays institutionalized. And because peers are the most experts, for instance, to do outreach, to create the safer space, the trust building, tailored answers that we need for migrants, women using drugs, people experience homelessness. I think thinking about this dialogical way on community and policy, constructing policy from a top-down perspective instead bottom-up grassroots lead perspective takes us to a distance in between what the people not only need but also desire versus what the state and the services want to let's say to put available for the people. That takes to the collapse of the service and everything else. And also another aspect I would like to mention is that the community of people who use drugs did all this almost without funding. So when you resource communities, they can even do more than we are doing now because we are resourceless. It means that the funding goes to the NGOs, to the state, and almost never arrive to peer-led projects. I would like to leave this note just to rethink a bit the way systems and the way we can reproduce systems inside our own organizations and services.
That is a great point, Joanna, and I think also touches on what both Shenia and Sophia was saying. You have to have systems that are built by people, and who are the best people to know what interventions work than the actual communities of people that have used drugs, that are using drugs, that have been in treatment, that are in treatment, and bringing these perspectives to others, and also having that feedback taken seriously. I think that's very, very important, and fun communities as well for it. Jalal, do you want to wrap us up?
Yeah, I said that very well, and actually pointed out what is happening around the world. And you know that the biggest barrier for drug policies in many countries, including Bangladesh, you know that Bangladesh is an overcrowded population. There is a 170 million, I say before that, you know that, yeah. There is everything is actually judged by religious thought and from religious perspective. If you use drugs, that means you will face a trial, you will face defamation in your society, in your family, that religious cleric would like to say that you are a disgrace to our society. So this is actually biggest barrier in the family from the bottom of the family, bottom of the society. You have to face this in the upper stick in the government. I would like to say that A to Z, you have to face barriers, you have to face challenges to get healthcare support. If I would like to say that recently Bangladesh government actually added that using drug is a mental health issue in addition to criminalization, actually. It's recently added by Bangladeshi government. Also that discouraging the drug users accessing essential health services and fear of arresting by law enforcement society, harassing by friends, colleagues, family members, relatives, and whatever they know, actually. So I have actually pointed out some barriers in Bangladesh perspective, that a strong socialistic stigma in here. It's what actually here? Social stigma. It's a if you would like to say that if you're a drug user, uh, you're a trash. Sorry to say, you have no future in the family. In your society, actually. So if you're a drug user, you will face a termination from your job. You will be jobless. You'll be jobless, and in the healthcare system, you'll face challenges from the doctors, nurse, whatever counselor, and in that Bangladesh, although is an overcrowded country, but there is a limited counselor, actually, trained counselor, and what is called specialist, counseling specialist, who can counsel, who can support a drug user to stand with a drug user. You can find there is a limited, actually. So insufficient employment opportunities for after rehabilitation, you can rarely find rehabilitation center in Bangladesh. If I can say to you that there is actually rehabilitation in divisional wise, you cannot find it in the district wise. You know that Bangladesh, we have drug users in rural and urban area, but it's equal, actually. Urban area people also use drugs, rural area people also use drugs, but you cannot find a rehabilitation center in everywhere. You cannot find government help, actually. But you can find you can find in real is harassing by law enforcement societies, law enforcement agencies. You can find disgrace by your neighbors, by families. So this is actually biggest problem. You cannot find a friendly counselor, actually. I saw that in many healthcare system, in many centers, hospitals. I actually, in my own experience, I saw that counselor here, like that, they behave aggressively, actually. It's not like a counselor. It's like that I'm facing someone I have enmity with. Oh my God, this is so embarrassing. What is called this? We need actually we need actually a civil society organization strongly working on this, and government to make drug user friendly policy for this a large number of people. I don't know it's going to happen or not, but we're trying to push government to make this policy that actually help the drug users. Thank you so much.
Thank you, Jalal. Thank you. And yeah, it's always a good reminder to see that there's unequal access in terms of regions, in terms of urban layout of services. That's always important. And if you have police that are dictating the way that people who use drugs are getting in touch with the state, quite often it's going to be through a violent measure. Great, thank you. These are all very good answers. I think we can move on to the next gap. Giselle, if you want to take it.
No, thank you, Andrea. Thank you, everyone. So super interesting, this conversation. And I give two ideas. The first one is that you mentioned, Joanna, the huge gap between what people might need and what people might desire in their journeys, and the huge distance from professional steps thing that people has to do and how this reproduces victimizations and institutional violence. And yeah, the second one is the collapse structures that we cannot ignore, which is a public health issue. So we have heard about many of the structural barriers that you mentioned that continue to prevent people from accessing appropriate care and exercising their rights, because we are talking about human rights here. But identifying the challenge is only the first step. I think the communities have done a great work identifying the challenge. But the thing is, how can we move on from here, just identifying how can we move forward and apply some solutions and do some changes? So our final discussion question today is, for you and the communities you represent, what does a more intersectional and person-centered approach to drug-related service look like? I would invite maybe Xenia to go first. Xenia, ¿te gustaría ir primero?
Sí, es difícil porque al final requiere estar revisándote todo el rato y revisar intervenciones y, como hemos dicho, también tener en cuenta con quién trabajas, como que la realidad, ¿no? Al final la realidad es muy cambiante y necesita que la intervención vaya cambiando. Entonces, por mucho que desde la entidad se creen estrategias, intervenciones, siempre va a ser una intervención individual y personalizada justo para cada persona, ¿no? Pero sí que como parte de estas entidades, igual que trabajan más a nivel comunitario, creo que le debemos a las personas que atendemos trasladar las dificultades que tienen de acceso, ¿no? De barreras, sus necesidades a otra, escalarlas un poco más hacia arriba, ¿no? Como dar un poco de voz, acompañar toda esa dificultad hacia otras esferas que sí que tengamos espacio las entidades y no poder que sean visibilizadas, que no se queden solo a nivel de terreno, a nivel de calle. Entonces sí que creo que una de los ejes importantes creo que es el trabajo en red, sobre todo, como tener en cuenta que al final pues trabajaremos con agentes del orden en nuestro día a día, porque seguirán estando allí, sobre todo si a nivel de ciudadanía seguimos votando partidos de derechas, entonces creeremos más en estados más punitivistas. Así que habrá que trabajar con policías y sensibilizando también todos esos agentes, creando puentes hacia estos servicios que sí que inicialmente pueden tener barreras de acceso. Creo que no nos tenemos como que mermar esa motivación, sino que hay que formar, hay que visibilizar todo este colectivo a personas, ya no simplemente al servicio en sí, sino el tú a tú, ¿no? Nosotros trabajamos un poco como en el tú a tú, de te escucho y escúchame tú, y entonces aquí como crear alianzas a nivel entre servicios, pero a nivel también individual, ¿no? Para ir abriendo, si no se pueden puertas, pues igual ventanas, ir creando como una red de apoyo y de soporte hacia este tipo de personas, pero no solo hacia este tipo de personas, sino hacia la diversidad de personas que formamos parte de la realidad, porque al final hay que, como decía antes, no me acuerdo quién era, pero que hay que romper el ellos y el nosotros. Al final todos somos nosotros y todos tenemos dificultades, así que qué menos que nos puedan atender en todas nuestras necesidades y no todas nuestras dificultades. Entonces creo que ahí está un poco como también la interseccionalidad y esa atención holística, que sea cual sea mi problema pueda ser atendido por esa red y que al final el personal que me atienda me mire como un humano, como una persona, sin juzgarme y escuchándome y siendo un poco empático. Creo que es mucho lo que quiero decir, entonces
Claro.
me cuesta un poco como ceñirme en el tiempo. Así que, bueno, lo dejo
Muchas
aquí
gracias.
y así ya dejo aportar.
Quizás tenemos unos minutitos luego, a ver si podemos, pero dos cuestiones muy importantes también que comentas, ¿no? Que como comentaba Joana, que los movimientos peer-to-peer no tenían financiamiento, y luego como si comparamos dentro de los diferentes tipos de servicio, aquellos que trabajan de manera más horizontal y con reducción de daños también son los que menos financiamiento reciben. O sea, hay como un castigo sistémico. Eso por un lado. Y luego, no sé si queréis también agregar esta narrativa que sigue vigente como si estuviera superado el estigma dentro de los equipos profesionales, ¿no? Como si fuera una cosa críptica. Es decir, depende, ¿no?, de los ámbitos profesionales, parece como si el estigma lo reproduciera la sociedad, que es algo también que está así un poco flotando. Así que, bueno, a partir de aquí, Joana, Sofía, Talal, ¿alguien quiere ir? Sofía, adelante, por favor, gracias.
Yes, so I want to say that I really agree with what Shenia said and Joanna said before about how historically in harm reduction, peers are the ones that have shown us the way forward. And all of these bottom-up initiatives are extremely important because of that reason. We need, like Shenia said as well, like the importance of working with the community hand in hand in a network. So I saw in the chat there's a question asking like, where does responsibility lie? If policymakers, health workers, society at large, and I think that it lies in all of us because, like Shenia said, it's not about the othering. We all use substances. There's a bit of hypocrisy about, for example, alcohol, because they'll criticize people who use weed or heroin, but then most people here in Colombia drink, for example. So in a way, we are all responsible, and we need to stop thinking that you are either a health worker, a policymaker, or some of these agents, because some people fall into more than one of these categories. So, for example, there's people who are health workers, but they also use substances, or they're policymakers, but they also use substances. So I think it's really important to maintain this idea of nothing about us without us, because for me, even as a professional, as a psychologist, some of us, including myself, are scared of coming forward and openly disclosing our substance use. When I believe that lived experience should not be a reason for exclusion or judgment, but it should be a plus, because you have more knowledge of substances, you have more knowledge of the communities, and you have a perspective that people who have not used substances, for example, or are not regular users might have. So I think we need services catered for users with people who actually know about substances, with peers. We need full spectrum harm reduction from a perspective of support and empathy and not punishment. We need evidence-based policies and services that drift away from moralism and criminalization. That has shown us time after time that it doesn't work. If criminalization and prevention work on themselves, they would have already worked. So we need to move away from those perspectives. So I think it's important to spread up-to-date, real, evidence-based information so communities have more autonomy over their substance use and the decision-making around it. And we need services with also inclusion of people who bring a gender perspective, and inclusion of, for example, people from the LGBTQI community, people who work there, people who have lived experience in all levels of decision making. From the community up to the policymaker to academia, we need people who are open about their substance use and who know about the topic we're talking about, but always surrounded with empathy and a humane treatment of people, as opposed from a moralistic perspective. So I think that's the most important part.
Muchísimas gracias, Sofía, por ajustarte al tiempo. Muchas cosas interesantes, es difícil resumir, pero me quedo también con una duda por si podemos cubrirla o por un tema que son realmente los mecanismos de participación significativos, ¿no? Si no corremos el riesgo de los últimos años de que lo hemos incorporado y lo estemos vaciando de contenido, también en cierta manera, y que realmente no sean reales. Lo dejo ahí porque quizás, ¿no?, luego poner en un checkbox he tenido una persona que usa drogas y he contestado un ítem y ya consideramos que ha participado. Joana?
Sorry. So yeah, building on that, I was in the EUDI summer school this week, and I heard something like from a prevention specialist saying it's better not have a recall on participation if you are using persons like tokens. So better to not have participation at all if you're doing tokenism. And then someone from the European Commission came and asked, do you think it's better not having at all participation? Because, you know, like some mechanisms, they exist, not for giving us, when I say us, the community of people who use drugs, decision-making. They exist to checklist. Okay, you are participating here and we consider you as experts, but we don't have to have you in account. The last decision, it's ours. And this goes for policy processes and this goes for services decision making. It's exactly the same thing. So as communities, of course, we want to have the space, even if we are not, let's say, taken until the end of the process. But looking at and I'm also an expert in public policy somehow, looking at the spectrum of policy participation, we can have, let's say, some informational first stage, like the information will be the first. So informing people so they are more capable and autonomous to take part in some decisions or to try to influence. We can have a collaborative approach, is that I'm engaging people who use drugs and they are my partner and they have some active partnership. But this is not the same as empowerment in leadership. It means that people who use drugs have the same power as the other structure and the same power of decision to challenge the power dynamics. This will be the last stage. It's not informational, it's not collaborative or consulting, like peer consulting, how do you say, boards that are sometimes in organizations. They are there to be consulted, but doesn't mean they are taken out in final decisions. So when we move to empowerment, and I don't like so much the word empowerment because we are giving power. No, we are sharing power. So let's put it in sharing power. Then we have effective partnerships with the community of people who use drugs. And we are giving out leadership and working towards to a joint commitment on leadership. And if we don't want to reproduce the dynamics where we can just use to as a checklist, okay, I have a person who uses drugs and works in my service, but what is the person who uses drugs doing? Cleaning your service in the end of the day? Or is the person doing safer injection because the person has a past in injecting, or a past or a present? It doesn't need to be a past experience in injecting. Or let's say a sex worker. What is the sex worker doing in your organization? It's like thinking about what the roles are the peer takings in your organizations, and also what space as professionals we open to more vulnerable peers in our organizations. What is the space we give? Because I think as part of organizations, we have the obligation, I would say, to foster peer-led participation and to have criteria on this participation, let's say minimum or maximum quality standards, I would like to say.
Muchísimas gracias.
And then we'll have a person-centered approach, of course, because people will be there at the center.
Muchísimas gracias, Joana, sobre todo por poner ejemplos tan prácticos y preguntas, ¿no? Que nos hacen preguntarnos a todas las personas realmente que si hay mecanismos de participación y si garantizan dignidad, derechos y participación real. Jalal, you want to wrap up?
Okay,
Yes.
thank you again. Of course, we need peer-led support. Not only peer-led support, we need community-friendly peer-led support, actually. We need more peer navigators, peer educators who can support, who can stay with, who can share their experience, who can make people happy, who can show an unstable person being stable, and who can say that it's not actually over. There is it's not like that. There is no one for you. We are here. We can support you. We can speak with you. Right. So, in my view, Bangladesh perspective, where I work in my where the community I work, actually I'm attached with, I handle several people in every day. So, the more intersectional and person-centered approach to drug-related services, like in Bangladesh, start with the people as individual rather than levels, such as drug users, HIV clients, you can say participate. Every person actually experience their shaped by multiple factors, including gender, poverty, sexual orientation, identity, social exclusion. You can, if you say that, family exclusion. I would say that word actually, because family don't behave friendly if you use drugs in my country. Okay, so. In Bangladesh, many people living with HIV faces overlapping forms of stigma. Not only drug users, drug and HIV co-infected people face this stigma even more strongly. There is no place for them if they cannot find us, actually, if they cannot find community-friendly peer people. There is no one left who can support them, who can help them, who can speak with them. In that case, we need actually community-friendly and drug user-friendly health service actually in here. That is absence, that is gaps in my country actually, if I say that. Someone may be living with HIV belongs to key population. I would like to say LGBTQ people, gender diverse people, what I call that minorities people. If you say that's ethnic people who are not actually mainstream people in this country, who are excluding from the rights, equal rights in a country. Actually, the constitution gave them. It's society. It's a society actually divided this. So who use drugs and experience poverty at the same time, who have HIV, use drugs and poverty. This is actually financial and drug using system. So, if it's become equivalent and equally you are doing this, there is a more stigma you will face, that you will thought that what can I do? What is left for me in future? It's like he will see the dark. He will see no one around him, and he will go up to a building, would like to go up for a rooftop and whatever it says. Sorry, I actually experienced that. I saved many people from suicide, who attempted to suicide. So I can say that it was really heartbreaking. People are really helpless who are belonging community and belonging from drug user community and HIV affected community. So from my experience, person-created care means providing actually integrated services where individuals can access HIV treatment, harm reduction, mental health support, social protection, legal assistance, psychological counseling, and coordinated with respectful way. Actually, in our hospitals, there is mass gathering. Every people, every types of people coming there for treatment. But if you're drug users, you will be seeing that people will look at you that they are seeing an animal in the zoo. Oh my
Okay,
God.
thank you very much, Jalal. Thank you very much for your answers.
Thank you.
And how important is to consider the intersectionality approach, because you were mentioning the HIV, poverty, and using drugs is not the same experience as other combination of discrimination. So this is key to take into account, and how do we design policies and treatment services in general. So thank you for highlight that, and thank you also much. I think today's discussions has left us a very clear message and a lot of new questions too, which is amazing too. So despite coming from different countries, organizations, and community, there is a remarkable consensus around what meaningful change requires. So with that in mind, also we can share the webpage of your organizations and some support resources or services that you think that could be useful for the audience. So feel free to share. We are going to do so. And before we close, Andrea, I would like to invite you to share any final reflections if you have. Over to you.
Yeah, thank you. I think it was really interesting to get a lot of these perspectives. I think even if we have different populations and different groups that we're considering, I think something that everyone touched on was about a meaningful inclusion and support of peers, people that know from experience, ideally from themselves, of what is needed for their community, whether they still belong to it or whether they know people that are connected to him, what's needed, and I think at the end of the day, as Joanna put it well, around the levels of engagement that you can have with this, and I think everyone also touched on it. Whether you are going to involve someone from the beginning of consulting on what needs to be done to actively sharing power on how you're going to shape a measure, that is always going to be important if you want to actually communicate, if you actually want to reach to people that are victims of stigma in society. So yeah, thank you so much for this discussion, everyone. Hopefully we got in touch with all the answers that we needed.
Voy a cambiar por última vez de idioma. Muchísimas gracias, André, y también muchísimas gracias a todo el mundo por haber hecho posible esta conversación. Esperamos realmente que nos haya permitido reflexionar y no solo formarnos para saber cosas, sino para transformarnos, ¿no? Transformar realmente nuestras prácticas a que sean más justas, éticas y garantes de derechos humanos. Así que de nuevo agradecer a nuestras panelistas maravillosas y maravilloso, a nuestros colegas de Youth Rights for this wonderful collaboration and for helping make this event possible. Y por nuestro intérprete, que lo hacemos ir de un idioma a otro, Patrick, muchísimas gracias por tu generosidad. Y por último, bueno, pues compartir esta idea, ¿no? De que el estigma no es inevitable. Está creado por los sistemas, las instituciones, las sociedades. Por lo tanto, también puede ser desafiado y desmantelado. Y en eso tenemos que seguir trabajando conjuntamente. Así que tengan un maravilloso día. Esperemos verles próximamente y que sigamos conectados. Adiós. Gracias por todo.
Gracias. Thank you, everyone.
Thank you, everyone. Thank you.
Thank you so much.
Bye bye.
Bye, thank you.
Gracias.